Dr. Ajay Shah with us. The theme is a discussion on a paper that he and his colleagues have worked on understanding the role of income and geography on health in India. This is based on a self-reported health database, longitudinal database that they've been working with. Could I have the next slide, please, Ulrich? The next slide. So the agenda is Dr. Shah is going to briefly present and talk about the work, and then we'll go into a Q&A session. I'll introduce Dr. Shah and then leave you in his hands. Dr. Ajay Shah is an alumni of IIT Bombay and USC. He's an economist and has held positions at the Center for Monitoring in the Indian Economy, the Indira Gandhi Institute for Development Research, the Department of Economic Affairs at the Ministry of Finance, and the National Institute for Public Finance Policy. If you haven't, I highly recommend checking out his book that he co-authored with Vijay Kelkar, In Service of the Republic, The Art and Science of Economic Policy. The book was featured in Bloomberg Global's 2020 Best Books in Business and Leadership. He's now part of the XKDR Forum and teaches at the Jindal Global University. Welcome, Dr. Shah.
Thanks, Ajay. Urvi, will you please play this show?
Yes, sir.
So I'm very happy to be. Yeah, I'm very happy to be here with all of you today. I'm here to report on the results of joint research between Ila Patnaik, Renuka Sane, S. V. Subramaniam, and myself. So we have 4 authors that have worked on this project. It took a long time getting. Here we are. We have some ideas on health in India. Okay, so as Ajay already said, this is about the role of income and geography in self-reported health. The working paper is out, and I invite everybody to read the paper. But here I am. I will do a short talk summarizing what we did and what we discovered. Okay, could you go to the next slide? In the field of health, one of the most important middle pieces is the measurement of health. So we are very interested in what causes health. We are very interested in the consequences of health. But for that, we've got, there are 3 pathways through which that is done. Okay, so one strategy is to do careful, thorough medical tests upon a person. And as you can imagine, this is difficult to do. The second good pathway is to go after mortality, whether it's infant mortality, longevity. Okay, mortality is a great measure. It's an objective measure. And what has happened is partly in India, mortality data is not so good. And partly we don't readily get mortality data associated with a whole lot of characteristics of the people in their life and in their death. So it's difficult to study mortality data other than at an aggregative level. And that is what brings us to the third pathway, which is self-reported health. Could you? Self-reported health is the simple idea that we build a household survey and we meet people and we ask them, how are you feeling today? Okay. Sometimes it's done as a scale of 1, 2, 3, 4, 5, or sometimes it's just a simple yes, no question. Are you feeling well today? Yes or no? Okay. It is a self-reported health measure. Therefore, it inevitably has limitations. As an example, if a person has diabetes, but they don't know it, they feel fine. Subjectively, they feel fine. It does bring psychological factors into the equation. Some people are more stoic. Some people get more hassled. So different people will behave differently. But if we build large-scale systematic data sets, then these psychological factors will be consistent across time, and on average, they will cancel out. And we are able to get a lot of useful value out of the self-reported health measure. So all over the world, an extensive literature has emerged where people are using the self-reported health measure. As an example, we know from papers outside India that it actually correlates nicely with an objective health measure, which is death. That is, that the people who report that they're not feeling well are more likely to die. It has many interesting connections to socioeconomic status in the published literature, and I'm going to show you more on these lines. Could we go to the next slide? We are working with an important new panel household data set in India. Okay, so for all of us who are medical research geeks or statistics geeks, we know the incredible power of longitudinal data. It is very, very, very powerful to see the same person across time. The CMI CPHS is a large-scale panel, that is longitudinal household data set. They attempt to measure 170,000 households, and they attempt to meet each of these households 3 times a year. And they amass a wide array of information about all these individuals and all these households. And particularly because of the causal identification that becomes possible with panel data and with household data, it's a remarkable moment where we can create better knowledge about the causes and consequences of health in India. There are many, many, many interesting research projects that can be conceived where we're analyzing the causes and consequences of health in India. This paper is intended as the first paper. This paper is intended to lay the foundations for a whole bunch of interesting specialized downstream projects. We want to write the first main paper on what do we know about self-reported health in India. Okay, could you go to the next slide? For that purpose, even though the data set is observed from January 2014 onwards, we chose to only use the 6 waves of 2018 and 2019. Remember, the household survey measures every household 3 times a year. So there are 3 waves a year. And we're only using the 6 waves of 2018 and 2019. Why is that? Because after 2019, you run into the pandemic, and before 2018, you run into demonetization. And those are all research questions. Meaning we should be studying what did demonetization do to self-reported health. We should be doing research, what did the pandemic do to self-reported health. But we wanted to build that foundational paper. This is the first paper. This is the basic facts. It's like a baseline of what is the nature of self-reported health in India. So in this data set, we see 170,000 households at least once. We see 736,000 individuals at least once. And the total sample size is 3.5 million, where one record is defined as one individual for one point in time. So it's a reasonably big data set. It's spread all over the country. And it's a unique moment where we are able to study the health of the people of India. Now in the paper, I'm going to use location intensively. And there I just want to explain that CMIE has cut up India into 102 pieces. So these are not the states of India. These are smaller than the states of India, but they're not the districts. So they have cut up India into 102 pieces. As an example, for Kerala, there is North Kerala, Middle Kerala, South Kerala. They do not allow you to study one district at a time, but it is better than only looking at Kerala. Okay, now let me start showing you the facts and the discoveries of this paper. So first fact, the first discovery of this paper. On average, the ill health rate is 3.25%. Okay, so if you meet 100 people and you ask each of them, are you feeling well today? 3.25% of them are saying, no, I'm not feeling good today. And that maps to about 44 million individuals in India who are unwell on any one day. Or alternatively, if you want to think about this across time, this is about 12 unwell days on average for one individual for 1 year. Okay, so this is the first interesting fact that we should all take away, that on average in India, people are unwell for about 12 days a year. There are about 44 million unwell people on any given day. Could you go to the next slide? Now we work out the age structure. So at different age groups, we find out what is the fraction of the people who report that they are unwell. And just notice that the Y scale is on log scale. So you need to think carefully while you're interpreting it. And what we see, unsurprisingly, is that young people are unwell and old people are unwell. And in the middle, we are all much healthier. The healthiest place to be is age 20 to 24. And by the time you get towards the right-hand side, there are numbers like 20% and 30%, which is a person is unwell on 1 in 5 days, 1 in 3 days. And straight away, when you start looking at this, we have been conjecturing in this paper that there is an interesting phenomenon of survivorship bias, which is that if a person is really unwell, they will die. For a person to survive and be there to meet a field investigator, they are actually in some ways the better off ones. Maybe they are a little healthier, maybe they have more access to healthcare. So, you know, being there as a person in India above age 70 is a rarity. And what we are seeing is the survivors. So there is a survivorship story leading into this data. So in the class of the people who make it into age 70 plus, 30% of them are saying that I'm not feeling well today. Could you go to the next slide? So in this table, what we're doing is that the columns are cut up by age groups. Okay, so this is age 0 to 4, this is age 5 to 9. Then we have clubbed together age 10 to 34. This is age 35 to 49. This is age 50 to 59. And we have clubbed together age 60 plus. And this shows you the overall pattern. The first row is the overall pattern. That is the same as the picture that I just showed you, that there are higher values here, like 2.21%. It drops to 0.91% at age 10 to 34. And it goes back up to 20% for the elderly. We take this and blow it up. We break it up across income quintiles and across regions. Okay, so for the 5 different income quintiles of India, we are seeing what is the age structure of self-reported health. And for the 6 regions of India, we're seeing what is the age structure of self-reported ill health. Okay, and we see some very interesting findings here. So let me start at age 10 to 34. Okay, in the age group 10 to 34, what you see is that the rich are reporting a self-reported ill health rate of 0.63%. And then it monotonically gets worse, 0.69, 0.81, 0.94, 1.23. Okay, so rich to poor, it gets worse monotonically in the age group 10 to 34. Let's take age 35 to 49, 1%, 1.2%, 1.3%, 1.6%, 2.49%. Again, it is monotonic. It is, however, not monotonic for the very young and the very old. Okay, so you see here, 2.12 is lower than 2.26, and then it goes to 2.23 again. Similarly, 20.42, 19.86, 21.82, these are not monotonic. Okay. So this is an interesting finding that income class and health is monotonically related in middle age, but this is not true for the very young, and this is not true for the very old. Why might that be happening? This is actually terrain for future research. In this paper, we have not answered this question. In this paper, we only conjecture that what is going on is a survivorship bias, that as you get richer, you're more likely to be around to answer the question, that poor people are more likely to just die. Okay, now let me turn to region. Under region, we are seeing dramatic variation in health. And what is more, it doesn't quite fit some of the things that we may have believed. Okay, so once again, let me go to middle age. For example, let's take age 35 to 49. The south is at 0.51. Then the next one is central is at 0.73. So this includes some of the Bimaru states, some of the Hindi heartland, but they're doing reasonably well. Then the west is at 1.04. The north is at 1.71. And there is really bad health in the east and in the northeast. So it's not your simple north-south story. In fact, it is the east and the northeast that is doing really badly. And I think this is another interesting finding from this paper. Okay, could we go to the next one? So we paint this on a map. There are 102 regions of India. And this first map that I'm showing you is just a very simple question. It is, there is some population. Tell me what percentage of the population is unhealthy. And what you see is that there are certain ill health hotspots. It is Bengal, it is South Kerala, it is Assam, it is East UP, it is Uttaranchal, and it is West Haryana. Okay, these are the hotspots where a large fraction, and there is a bit of a problem here. These are the hotspots where a large fraction of the people are unwell. This is self-reported health. So for example, Karnataka looks great. Okay, for example, Rajasthan looks great. For example, Maharashtra looks good, and so on. Okay, so these are interesting new findings. We are getting a geographic structure of the ill health rate, and it's a lovely map. We should all have this map on our walls because it shows us where unwell people are. Okay, so I don't care about the reasons. Where is the fraction of the population that is unwell relatively high? And this map is showing us where these unwell people are. But when you pause to think for a moment, there are so many things going on. Could it be that the demographic structure is different. For example, we have more old people in Kerala. So we will expect to see older people in Kerala. It would be very interesting to be able to attribute something to the place, something to the location, that there are certain places in India where there's something wrong with the place and we have higher ill health. So then you need to purge the data out of the demographic structure. Similarly, some part of this is just economics. There are some poor people. Okay, so maybe when you have more poor people, you'll always have ill health. From a public health point of view, poverty is not a health problem. From a public health point of view, we would like to do the public goods of health. So, we would like to get clean drinking water. We'd like to do more vaccination. These are not poverty problems. So once again, we would like to purge the data of wealth. Can we remove access to private healthcare from the picture because we are controlling for income? So that's what we now set out to do, that we're going to try to control for demographic structure. We're going to try to control for income. And then we will revisit the question of geography, and we will get maps of India that are deeper and that reveal something about the geography of ill health in India, and not the mere geography of demographics and the geography of economics. Okay, so can we go to the next slide, please? So we're going to estimate a bunch of logit models where we have covariates about income and age structure and so on. And then we're going to introduce a location fixed effect, which will pick up the unique characteristics of each of the 102 regions of India. We're also going to allow the income coefficient to vary by location. And this is a very interesting and deep idea. And now I'm going to show you what are the findings from this. And I will emphasize the interpretation. Here in this talk, I'm not going to emphasize the technical details. I'm happy to discuss statistics with any of you separately. I am a statistics geek. I'm always happy to talk more about statistics. But right now I'm going to talk more about the insights and the interpretation. Could we please go to the next slide? Can you please skip this slide? Can you go to the next slide? Can you please go to the next slide? Can you please? Okay, stop here. Yeah, this is where I want to go. So we have estimated some statistical models where we are able to get predictions about the ill health probability for every single person after taking into account their income, their age, and their location. Now we want to say, show me the pure effect of geography. I don't want to worry about demographic variation. Yeah, sure, there are more old people in Kerala. I don't want to get distracted by demographic structure, and I don't want to get distracted by differences in income. I want to only focus on the variation by location. So for that, what we do is we focus on exactly one person. We find the commonest category of an individual in India, and that turns out to be a Hindu male, age 35 to 49, who is SC/ST, who has class 12 education, is a rural household, had a family income of 13,000 rupees per month. Okay, this is the commonest individual out of all the different kinds of individuals in India. And for this individual, we use statistical models and we predict the ill health probability of the same identical person in all the 102 different regions of India. So could we go to the next slide? Okay, and this shows us the intra-India variation of the ill health rate for that same person. So now we have controlled for income, we have controlled for age structure. Now we are saying that same kind of individual, age 35 to 49, Hindu male, SC/ST, class 12, family income 13,000. This is the intra-India variation of the health of that same socioeconomic characteristics. Now we have to think more. What the hell is going on? What is wrong with Uttaranchal? Why is that same person wearing Himachal Pradesh? What's going on in Assam? Why are people so unhealthy in Assam? What's going on in South Bengal? What's going on in South Kerala? North Kerala is a bit better. Okay. What's going on here in Eastern UP? And in fact, in many ways, you find this pattern is actually similar to the previous pattern. We think this takes us to epidemiology. There is something going on in Uttaranchal, which is generating ill health in Uttaranchal, and it is not explained by mere income and mere demographic structure. There's something more going on. This is like Jon Snow's map, that we need to look at this map and then we need to start going and doing detective work to figure out what the hell is going on. And I do not have an answer. We have some opinions, we have some conjectures, we do not have answers. But fundamentally, I want to say to you that this is an interesting and important finding, that what we're seeing is a geographic structure of very high variation of ill health. And actually, this is the bulk of the story. If you compare this map against the previous map, they look so much alike, which means that what is at work is not income. What is at work is not the age structure. What is at work is something else. And what that something else is the subject of statistics and epidemiology to go discover what might be going on. So we think that this map is a very interesting and important discovery, using which we should kick off many new research projects in understanding why there are these disease hotspots in India. Could you go to the next slide? Okay, next we're going to go after the role of income. Okay, so normally what you would expect is that richer people would have better health, and on average, overall, that is indeed the case. But go to the next slide, and we're going to turn this into a map. So for each of the 102 regions of India, we're going to ask the question that when you become richer, does the ill health rate go down? The blue places are where this is indeed the case, that as you become richer, the ill health rate goes down. And that's great. That's what you would normally expect. Every reason imaginable points to this. So when you become richer, note, this is the household becoming richer. When the household becomes richer, so the richer households are healthier than poor households. Why? Because they would have better nutrition, they would have better housing, there would be less of vector-borne disease given the fact that the housing is better, and they would have more access to private healthcare. Okay, so these are all reasons why you would expect that richer people would do better. But what is astonishing and something that we need to think about deeply is that a large part of the country is actually white or red. What is white? Rich people and poor people are equally unwell in the white regions. And what is red? The rich people are sicker than poor people in the red regions. The slope is actually going down. Okay, so blue is where the rich people are healthier than the poor people. White is where rich people and poor people are equally bad. And the red is where the rich people are worse than the poor people in terms of being unhealthy. What might be going on? We really don't know. Once again, we think this is an important discovery. Right now, I just want to show it to you like this is a Jon Snow map. That there's something going on, and we need a whole body of research on understanding these phenomena. We think these are grand questions for the health community in India, and we think a whole array of work is required in understanding and deciphering these questions. Could we go on to the next slide? Okay, so how do you interpret the geographical variation of the ill health rate? This is the previous map. Why is Uttarakhand so bad? Here's some conjectures. Again, these are pure conjectures. We have no proof at all. Could it be that a lot of pilgrims are coming to Uttarakhand and bringing infectious disease to Uttarakhand? Could this be a phenomenon with Kerala as well? That Kerala is highly internationalized, and there are people traveling in from many, many countries who will constantly be bringing in new diseases and new variants into Kerala. And from all over the country, people are bringing disease to Uttarakhand, which is of course amplified by the unhygienic conditions in which the pilgrims move around inside Uttarakhand. Could it be that there is arsenic in the water in Assam and West Bengal, which is generating the difficulties of ill health there? Could it be that public health works better in some places than others? Could it be that healthcare works better in some places than others? We don't know. But these are the kind of explorations that need to now begin, and a lot of research is required on these questions. Could you please go to the next slide? Similarly, how do you think about the geographical variation in the slope of income? Higher income ought to help. With higher, richer households should be better on knowledge, on nutrition, on housing, on healthcare. So imagine if there is no healthcare at all. There's really no reasonable way in which you can get rich people being worse than poor people, or rich people being equally bad as poor people. Perhaps there's a combination of survivorship bias and diet and healthcare going on, which is that with poor people, When you are unwell, you're likely to die, whereas the rich live and live and are there to answer the questions of a field investigator. Could it be diet, that rich people are eating really badly and then they end up in ill health? Could it be that healthcare in many parts of India is really bad, that actually the healthcare makes you worse? Again, we have no idea. We do not have any clue on what might be going on. We just want to say these are fundamental, foundational questions in the field of health in India, and many research projects need to take off on deciphering the good quality causal explanations of the mere statistical regularities that we have created. We have created John Snow's map. Now we need detective work to go say this is cholera because of this pump. Could you go to the next slide? So to conclude, self-reported health measured in panel data is a whole new world in terms of studying health in India. Longitudinal data opens up remarkable opportunities to measure and to study causes and consequences. We have scratched the surface. We've written the first paper. So we think of this as the first paper on studying self-reported health using this data set. We have developed some broad facts. We have discovered some broad facts about SRH. We've isolated age and income as being important things, but really the grand drama seems to be location. Location seems to be incredibly important. And going by these regularities, just becoming richer will help households in about half of India, but not in the other half of India, and lots of new work is required. Could you please go to the next slide? Okay, my co-authors and I are very happy to discuss these things further with you and collaborate on all kinds of research projects. At the URL, you will find paper, a video of the talk, and many other materials that have come out connected with this work. So now can we switch off the slideshow, and we are about 30 minutes in, so I feel it gives us about 30 minutes to do a broader conversation.
Thank you, Dr. Shah. So we'll open this up for Q&A. I had a very quick question to kick it off. I'll also request anyone who has a question to please raise their hands, and also please introduce yourselves before asking the question. But a quick question from me to begin with is, can you tell us a little more about the study itself and the selection of these 170,000 households? You know, how was that done? Any more granular detail that we used?
So CMIE is Center for Monitoring Indian Economy. They are a data building organization. In 2007, they started building the methods for creating a random sample in India and measuring them 3 times a year. The release of their data commenced from 2014. So they spent 7 years in development. And from January 2014 onwards, they have started the release of this data. This data is available to all researchers on payment of a subscription fee. So there are about 50 universities all over the world who have access to this data, the identical data that we have used in this data set. What they're doing is the normal methods of random sampling. So they start from the CEB, the census enumeration blocks, which identify all the structures of India. They have a stratified random sampling for very large cities, cities, and villages. And they are using standard techniques of sampling to find those 170,000 households all over India.
Thank you so much. I'd like to call on Dr. Deepika.
So thank you very much for this amazing presentation. And I can't tell you how excited I am about the possible questions that can be raised and that can be answered. So first of all, of course, I'm an epidemiologist, a public health person, and also a clinician. And so probably I can help with the decoding of the mysteries that have been created. So I have worked with ICMR in AIMS. So it has given me some exposure into these kind of things. And I may be knowing a few of the purely health data sets, which might be of use to you, because you've been working in the economic field and the public health field. I mean, also there are many such, not many, but a few such things have happened. And if we could enrich ourselves from that and this, and then go ahead with it, then it will be, I think, a very good body of work.
Thank you very much, Deepika. We would love to collaborate, and we would love to carry this research program further. So, let's get talking, and I'm very keen to find possibilities to work in an interdisciplinary way across professions.
Sure.
Do you have a question, Dr. Deepika?
What I had was that, this is coming from the mind of an epidemiologist, is that was there any disaggregation in terms of the disease burden which is there across India as per different regions?
In this current data set, it is not there. They have questions on health that pertain to this one, self-reported health. Then they measure hospitalization events. They ask a person, are you taking a medicine today? And they ask about expenses on health. But they are not doing any disaggregation about the sources of the disease burden. So in their off-the-shelf data set, this is what is observed. And potentially in the future, some of us, we should be able to work with them and extend their data into asking more questions. But currently what is available off the shelf, longitudinal data from 2014 onwards, just has this one question. Are you feeling well today? Also, are you taking a medicine today?
Yeah, so that would be like from, pardon me, but from a medical and from a public health perspective, I would say that there are, that now that means the data is, merged a lot.
Yes.
And so if we go and demerge it or disaggregate it, then we may have quite a few answers from the data itself.
You're absolutely right. These are all things worth doing and worth chasing down. But just in terms of the cost and complexity, this is what is there off the shelf.
Okay, fine. That helps to know. And definitely, I would like to talk to you in more detail about, after reading the paper, on what would be the most important thing to take forward first, and how we can, really go and do a deep dive into this.
Thanks.
Thank you, Dr. Deepika. I'll call on Ananya next. Ananya. Then Parag Agarwal.
Yeah, hi, good evening. Thank you so much for this, really interesting. I look after partnerships and international business at Meadow Oxford. So we are in the outpatient digitization and provision of care, and we are mostly in the metro cities. I had a question around whether this kind of study has been compared with anything done in the outpatient side, because it's all self-reported data. And I remember CIPLA and Chest Research Foundation, I think, published something in 2015, where over one day, they asked more than 12,000 doctors to just give them 1 day's worth of prescriptions just to see the disease profile of the country. I'm not sure if you're aware of that study. And I think more than seven.
I was not aware of the study. It sounds like a great idea.
Yeah. So
you would need random sampling, and I don't know how to do that. Meaning, how to make a random sample of 12,000 doctors sounds hard to me. If they've actually done this using random sampling, it would be very useful. If not, it would largely not be useful.
Correct. So this was I mean, I'm not an expert in statistics. I'm not sure how this was done. But so I just wanted to check also on, the self-reporting nature. I noticed like the West, across all different age groups, very few people reported ill health. Yeah. Do you find a cultural bias that, if someone's asking a question, they will generally say, if you're from the West, that I'm feeling well, they're not going to report that they are ill, even if they are.
Yeah, that's a great question. And all over the world, there has been a lot of debate about the extent to which cultural factors interfere in the mapping from the true state of ill health to a self-reported health. Okay, and each of us, we are different human beings. I may be less stoic than you. So for the same objective level of ill health, I might put a chin up and say, no, I'm feeling great. Whereas other people might say, oh, I'm feeling absolutely terrible. So that is indeed a factor. Now, look carefully, for example, at Haryana. And people who know Haryana well tell me Haryana is very homogeneous culturally. But the ill health is dramatically different across the HRs of Haryana. Interesting. So even though there's cultural homogeneity, the self-reported ill health differences are picking up something, that there is sharp variation. Similarly, UP. Note the difference between Eastern UP and Western UP. Western UP is much worse. You would agree that there is fair cultural homogeneity. Similarly, Kerala, and so on. So if hypothetically the values being reported would just be driven by culture, then they would tend to be homogeneous within states. It's not too much the case.
Yeah.
Another way to think about this is that no two humans are alike. And as long as the sources of variation, the psychological factors, are reasonably random, then in a large data set, they'll tend to cancel out. And we will succeed in picking up the systematic patterns. So we are not here to make a claim that individual I is genuinely well or unwell. We are here to find averages over 3.5 million observations and report some grand facts that illuminate us and give us better insight into the state of health in the country.
So just one final point. So I think the other thing which could be interesting is, a mapping of pollution over the 3 different waves.
Yeah.
And because that's also very location specific. And it's, especially in the last 7-8 years, there's been a lot of detailed measurements.
Good idea. It's worth doing, yes.
And, so I think if you overlay the 2 maps, the first thing that came to mind north, especially Delhi, NCR region, was there any report?
By the way, just so that all of you know where we are going, I have already told Ajay Nair about this. The second paper in this field that we have done is mortality. So it's longitudinal data. The CMIE field investigator goes back and meets the same household every 3 months.
Yeah.
And they have an inventory of all the family members. And sometimes the household says X died. So a certain person died. And we get that recorded in the database. So we were the first people to come up with the idea that you could use this to measure excess mortality in COVID-19. Okay. And our second paper is a similar socioeconomic characteristics and geography explaining death. And by the way, I will preview one fascinating finding there. In the Indian data also, we find that self-reported health matters. So in wave I, if you say I'm not feeling well, your chance of being dead in wave I+1 is higher. So again, that persuades us that there is some objective truth in the SRH, which we should take interest in.
Sure. Great. Thank you so much.
Thank you. Dr. Raman Kataria.
Hi, I'm a public health physician and also a clinician working in Chhattisgarh. I just wanted to know, one is that, is there a clear hypothesis that you started with when you started this research with?
We started with no hypothesis. We said to ourselves, we're holding an amazing new database and very little is known about health in India. Can we establish some basic facts? So this is a statistical regularities paper rather than a hypothesis testing paper.
So, why pick up certain things and not others?
There are many directions to go. It was just where our curiosity went. It is an important new database and hundreds of things need to be done. So we just wanted to get started with the first paper.
And I'm curious to know why 102 pieces of India, why not go by either the districts or the divisions, or at least the divisions, because they would hold already certain data sets which will be important and they can be mapped easily once you have that data collected accordingly. So whether it is morbidity or mortality data that already exists.
So this is not our decision, it is the decision of CMIE. They started with a budget of 170,000 households. Okay, this is the world's biggest household survey database. And for whatever reasons, their financial constraints were that they could cover 170,000 households. Now you have to start thinking, how would I distribute 170,000 households in India? It turns out that if you divide by about 730 districts, you get a weak sample in every district. So 100 is a number where you take 170,000 divide by 100 and you get a strong sample in every homogeneous region. So then they go and solve the sampling problem on each homogeneous region separately. So what they guarantee the researcher is that within each homogeneous region, they have done a thorough statistical sampling. They do not guarantee that sampling is being done correctly in every district. So this is their production problems and funding problems of how to create a database.
Okay, essentially, if one is building on something which already has significant limitations, I would think that something better. Obviously, this is a start, but something better could have been done.
So it comes to, I mean, all of us know, like, there is an NFHS data set. In some ways, it's great. In some ways, it has huge limitations. Most notably, it's not longitudinal data. It's just not frequent enough to meaningfully track the events of the country. And then there are no other nationwide regular data sets. So I think this is an important advance. And of course, we would always like these data sets to be bigger. But I'll also point out in passing that this is the world's largest household survey data set.
Thank you.
Thank you, Dr. Kataria. Sudita?
Yeah, thank you. Thank you, Ajay. This was a fascinating talk. Really enjoyed this. So I'm working with Government of India on the National NCD program. And I was curious to see if you looked at how this maps to the NCD burden, and is there a correlation? This is something that we'll definitely go and look tomorrow. I'm really curious to see how this maps to that. But so that was the first question. And the second one was, did religion have any part to play? Is there, because this is self-reported, is there an element of, either stoicism or fate or karma or whatever? Was that, did that play a role in some pockets? Or, yeah, so, those were my two.
Yeah, the first question on NCD versus CD, we see nothing. So this is the same question that Deepika asked earlier, that is there any breakdown of what is the nature of illness? The answer is no. CMI is only asking each individual, are you feeling well today? That's all, there's nothing else. So we have no way of breaking down NCD versus infectious disease. On the second question, when you read the paper in detail, and I hope you will, and I would love to discuss this with you further, there are empirical regularities where Hindus, Muslims, and other religions are significantly different, and other religions are dramatically healthier than Hindus and Muslims. But after you control for income and location, these differences basically go away. So what's basically going on is probably that Christians are higher income and are in certain places, and so in model 3, which is the best model of the paper, religion is a very small effect. It's really not there.
Okay, thank you.
Thank you, Sunita. A couple of quick questions from me on this is that, in the same survey, there was also expenditure and medication. Is that something that you're planning to look at and overlay with the same question?
There is many research projects which will flow from this, and we are keen to collaborate with everybody on this call. So, whatever pieces of this you find interesting, please talk to us. We'd love to work with more people on all these things.
Thank you so much. I'm trying to see if there's any more questions. If not, then we can close the call. Any last words, Dr. Shah?
Just thank you very much for bringing me here. This is a beginning with a new data set. We're starting to discover some facts about the world. Would love to work with others in pursuing different dimensions of curiosity, interlinking to your knowledge and your intuition.
Thank you so much. And Dr. Shah's email is in the chat, but if anyone reaches out to our team, he'll also get back and share his coordinates so you guys can get in touch directly. Thank you all and have a great evening.
Thanks, Ajay. Bye-bye.
Right.
Thank you.